So there were quite a few questions about the extended health benefits coverage for RPs and what the college's position is on that, and RP recognition. I think you addressed it, Deb, but if there was anything that you wanted to add or direct people to on the website.
Sure. So the issue of third-party coverage is one that we're very aware of. I know that as the other provinces come online and there's broader coverage across the country, our understanding is that the insurance benefit that covers RP services. We do have the position on the access to care statement posted on the website. I'd encourage you to have a look at it. I know that our association colleagues use it and refer to it when they're having conversations with the relevant groups at government and in insurance provision when they're looking to expand the coverage that's available. I know that the associations are working hard on this front. It's their wheelhouse. And so I would encourage you, if you're not already engaged with one of the professional associations, to consider getting engaged with them, because this is one of the places where they have good work to do.
Great. We also received a couple of questions about HST, which I think you also addressed, but if you wanted to speak a little bit more to that.
Sure, dispense with that one up front. So again, this is an issue that the college really has no formal or official role or authority with. We do have that position statement that says barriers to access are a problem, and we recognize that the requirement that you charge HST is a barrier, and so we do weigh in appropriately from a regulatory perspective when we can, and I would encourage you to work with your associations. I know they're doing a lot on this front and are working in a very focused way, in a very collaborative way, to try and address it. As we see more provinces come online, and that seems to be starting to roll in BC, we're waiting on Alberta imminently to be regulated, and I understand that the East Coast provinces we already have New Brunswick and Nova Scotia, but the other East Coast provinces are getting closer. Hopefully that will help, and we are in touch with our colleagues in those provinces, so wherever there's a regulatory piece that could be contributed to the conversation about HST, we will be contributing it.
Thank you. Another question that we received is, along the lines of inclusion and diversity, I would like to know what updates CRPO has about its submission to the ministry about allowing RPs to serve as secondary referrers for gender-affirming surgeries in the province. Currently, RSWs and psychologists are able to do this, but not RPs.
That's a good question. We've made 2 submissions to ministry through letters over the last 3 years, and have not had any formal response to date. The last submission was right before the pandemic, and so all eyes have been focused on that, and so there hasn't been a lot of movement. It is definitely an issue, and certainly one that we need to address and that we will be pushing forward. I'm sorry that we haven't seen more progress, but it is on council's radar and something that needs to be considered. It's part of a larger conversation about the recognition of the RP title. So also for things like auto insurance benefits. And our deputy registrar is part of that conversation at a working group at the provincial level to try and recognize and have RPs added to the list of providers who are included in that benefit. So we will continue to work on it and look for updates and ask again.
Thank you. And again, in the chat feature, I see that Stacy Jenkins has put a note about RPs interested in circulating a petition to the government to remove HST, and she's provided a link there.
Great, thank you.
A couple of questions relating to complaints. The first one is, what is an RP's role in terms of reporting when they become aware of an unregulated professional behaving unethically? If you report the incident to a manager, is that enough?
So it's a starting point for sure, as close to the problem as possible. In terms of CRPO's authority, we can only step in when there's unauthorized practice. So if somebody was holding out as a registered psychotherapist using one of the associated titles or was clearly practicing the controlled act, we would have the ability to intervene around unauthorized practice. But in terms of quality of service of unregulated providers and issues with unregulated providers, if it's an employment issue, as it seems from the question, that would be the place to start. We don't have any authority over the quality of services, provided that they are not stepping into the territory of controlled act or holding out as a psychotherapist. But it's always worth the inquiry. If you think that somebody is holding themselves out as a psychotherapist or performing the controlled act, I'd encourage you to email complaints@crpo.ca. I'll walk through with you and figure out what's going on.
Thanks. Sorry, lots of questions coming in fast and furious. The other complaints related question was when you were going through the sort of numbers about issues that are identified in complaints, somebody raised the question about the nature of the communications issues. Like, what would be an example of a communications issue?
In terms of the allegations. Shelley, do you want to speak to that?
Sure. So an example of that would be an unprofessional communication or failing to communicate in a timely manner. So perhaps a client left several messages, the RP didn't respond, or in the way they were communicating, it was unprofessional. I think that's, and I don't think there's anything outside of that. It's really just about the manner in which they communicate with other professionals or their clients.
Mm-hmm. And one of the things that I've seen is one of the moments where it can be a bit fraught is around termination of care. And so the need to ensure that effective, clear, comprehensive, upfront communication happens when termination of care is needed or warranted. So it would be one of the areas that I would encourage folks to really think about the standards and consult if you have any concerns in terms of getting ready to do that with a client.
The next question is, can you please address the issue of what to do with clinical case notes and files if an RP were to put their license on hold, or if were to practice outside of the Ontario jurisdiction?
Good question. Thank you for asking that, because it gives me an opportunity to talk about a survey that's coming out in our next communique around having a designate and the storage of records. So you are obligated as regulated providers, as are all regulated healthcare providers, to retain your records and to make them available to clients in the future under certain circumstances. So for example, if you decide to retire or resign your practice and move away. So we are looking at finding out how many of our registrants have a delegate who has the responsibility once they leave practice of making records available to clients should they request them within the time frame that they're required to be held for. So you, regardless of what your decision comes from, whether it's because you're moving out of province or you're putting your registration on hold or you're outright resigning from the profession, you need to make sure that there's a plan in place. So there are firms that do this. You could designate another registered professional. That's the ideal scenario because they would be in the best position to manage records afterwards. Certainly in the case where we see with registrants who've retired and died, there are sometimes issues where they have not in their will and have not designated somebody from their estate to be responsible for records. So we're actually reaching out to find out what the status is and then to try and provide some recommendations and some resources around how you might go about planning for that end of your practice or that pause in your practice. The standards are quite clear about how long and in what format, and you're also governed by the sorry, I always have to think IPC, Information and Privacy Commissioner's directives around how to manage personal health information, which is what a psychotherapy record is. I hope that answers the question. If not, please feel free to follow up.
The next question is about assessing clients' need for resuming in-person services and whether there are any resources to assist in doing this assessment. I'm referring to online document from Dr. David Williams entitled Directive Number 2, and a quote from this document. This requires considering the differential benefits and burdens to patients and patient populations, as well as available alternatives to relieve pain and suffering. How exactly are we to do this with adult clients?
So this is a question we've had a couple of times at the practice inquiry line, and one of the pieces that we will hope to address with the webinar that we're planning. But what I will say is to repeat what we've sort of maintained all along, is that your clinical judgment as a provider, knowing your client, is what should direct that. So as it stands, you're still permitted to provide in-person care. In fact, you always were, where it was urgent, provided that the appropriate infection protection and prevention and control measures were in place. Recognize that's hard. It's hard to, get the 6 feet and the masks and all the other pieces that you need. But your clinical judgment will guide you in terms of what your clients need. The college has not taken a position where we say this constitutes a need. If you go on and you read in the startup documents that David Williams provided as part of the return to work, he talks about clinicians being the ones who are in the best possible position to determine what needs look like. And he offers the principles, and I'm going to forget what they are. It starts with proportionality. I'm sorry, I'm blanking on what the other 2 principles are, but he provides that framework within which you should be considering the needs. So, I'm reluctant to sort of say, here's the clear, bright line of need and not need, because ultimately, as a clinician, your clients and what their needs are. But the webinar is going to try and tackle that in a more direct and practical way.
Next, we have another fee-related question. This one is, can we address the lack of uniformed fees in the profession? Is there any talk about a fee schedule so we're all in line with one another?
No, not from the college. This is well outside our wheelhouse. We talk about standards around being transparent and consistent, and we provide guidance on billing practices, but it is not for your regulatory college to tell you how much to charge. It's maybe something the association wishes to pick up. Certainly, if you look at your physician counterparts, their association is very involved in setting fees, different relationship because of the OHIP coverage, but it is clearly and definitely one of the places where the college dare not tread. You wouldn't want us to. The piece about the college and remuneration for registrants is that we lose the public trust as soon as we start to have conversations about how much RPs should be paid. So I'm going to use this as an opportunity to talk about the 3 pillars of a healthy profession. So strong and robust associations that protect your interest as RPs, a reliable and consistent regulatory framework that ensures that you're accountable and providing safe and ethical care, and then a healthy, accessible education system that graduates excellent practitioners. And so the convergence of those 3 is where the profession becomes sustainable. And so certainly we appreciate at the college that billing and fees are part of what make the profession sustainable. And so, there's no role for the college, but we do appreciate that you need to be able to make a living in order to be able to continue to practice. And so the best thing that we can do for you on the front of remuneration is set the standard and then get out of your way so that you can do that work with your associations to set fees. I hope that helps. Shelley, I don't know if you wanted to add to that.
Yeah, I was just going to say that, yeah, you're right. That's outside of the scope of the CRPO. However, if a complaint comes through the ICRC where a client felt that the fees that the RP was charging were excessive, that would be grounds for us to look into the fees that are being set.
Yeah, absolutely.
Or the
Reasonableness.
fees that are being charged.
Yep.
Next question is, at a previous CRPO roundtable, you explored ideas around subtle kinds of conflict of interest between RPs and clients. Is that issue considered fully explored now, or is CRPO looking into that more? For example, an RP renting office space from a client.
Thank you. I appreciate the clarification. So the standard around dual roles and boundaries is there, and I think is quite clear. Certainly, if there is more explication needed on those standards, it's something that we're happy to provide, either to the individual practitioner who's asking. One of the things I'll just as an aside point out that when we get questions to our practice inquiry, we often use them to create practice matters articles later or to post them on the website as part of our FAQ, so everybody benefits from them. So certainly if you have that question and want it posted more prominently, please go ahead and ask it and we'll make sure we do. We look at each case on an individual basis. Shelley can speak to that as the chair of the ICRC. Certainly in terms of how we respond to complaints, there's always the opportunity for the registrant submissions to explain what's going on in a given situation. But certainly I would suggest that complaints where boundary crossings have occurred are quite frequent. And so would really encourage you to look at the standard, and if it's not clear to you how that would apply in your situation, if it's about renting space or some other dual role, landlord tenant, please do reach out proactively so that we can respond. But it is one of the areas where the opportunity for confusion and lack of clarity to lead to complaint is pretty big.
Next question is, when my position with an organization was laid off and then terminated, I consulted with a practice advisor and received excellent support regarding the moral dilemma of one's therapeutic responsibility. Is there any role for the CRPO in communicating with organizations who include psychotherapeutic support roles about the responsibility they need to have for severing the therapeutic relationships when they terminate a role?
Thank you. That's a great question, and certainly one that Council has spoken about on a number of fronts. What is our role vis-a-vis employers? We regulate individuals, but we recognize that those individuals are very much, buffeted by the employment relationships that they might have. And so I think that the part of the answer to that question is that looking to make appointments to committees of RPs who work in different situations, including those kinds of employment situations, we are hoping to be able to be more responsive and to find our way in terms of communication with employers. We certainly answer questions. We actually get them quite frequently to the inquiry line from employers who are trying to understand, how best to support and oversee RPs working in their practice. But it is certainly a consideration and one of the places where we have our sights set in terms of deciding how much further we need to go in communicating.
We also received a question a little bit earlier. How do we connect with peer circles?
So as it stands, the one that we're offering next week at the Ontario Association of Mental Health Professionals Conference is full, which is great. I'm really thrilled to see that. We will be scheduling, I am hoping in November. We're trying to squeeze in some sessions before we lose everybody to the madness of the winter holidays, and then in the new year. So you'll hear from us. We will be posting dates and inviting people to sign up. Our original plan was to dovetail, so what I'm looking for, dovetail the peer circle sessions with the town halls that we were going to run in the various districts in person. Part of the benefit of peer circles is that it gives you an opportunity to network. and connect with other professionals in your community who you might not otherwise have an opportunity to engage with. So we're losing that to some extent because we won't be running them regionally. What we hope to gain on the upside is that they will be much easier for you to attend. So we'll be looking at offering them at various times during the day. So if you can sneak a couple hours in over lunchtime, we'll be looking at evening and afternoon sessions, and we might even, if the interest is there, consider offering weekend sessions as well. So please look out for that. We'll be doing a lot to market those once the dates are set.
Next question is, does a manager in a hospital setting have the right to read through clinical case notes randomly? If so, what is the process?
That's a good question. Hard to know specifically what the situation is. What I would offer is that there are health custodians and then those health record custodians under the privacy legislation in Ontario and agents under the privacy legislation in Ontario. It would be, the starting point would be for you to determine who's the custodian of that record and who's the agent, if you work in a hospital, for example, and what rights and responsibilities each of those different roles carry with them. And to be really clear about what your employer's policies are around access to health information. Certainly it gets more complicated, we know, with mental health records, and the fact that clients can choose a lockbox or should be able to choose a lockbox within their record. If you're a shared team, for example, quite reasonable for the client to say, it's fine for the secretary and the dietitian to be able to see my blood results. That's part of the work that they need to do. I don't want them to see my therapy notes, but you would need to be clear on what your organization's policies dictate and go from there. I'd encourage you to look at the PHIPAA legislation. We do have some resources posted relative to that, particularly around the healthcare custodian versus agent, because I think that might be what's at play here. I'm sorry, that's not a binary answer for you. Hopefully it provides the direction you need, though, to figure out what the right course of action might be.
The next question. Sorry, I lost my place.
I'm watching the questions come in, folks. Thank you. It's great. They're fast and furious.
So this question is about CRPO fees.
Okay.
Therapists pay the highest registration fees of all the colleges. Will there be a reduction in registration fees?
So in actual fact, that isn't accurate. The CRPO fees out of the 26 colleges that are running in Ontario at this point are actually on the lower end. I know that we are higher than social workers, which is not a health college, but shares the Controlled Act and has some of the same same scope. And so it's often a question that we get relative to social workers. There are lots more social workers than there are registered psychotherapists, and they have been around for a lot longer as a regulated professional group. So the fees that CRPO charges are carefully considered every year. We have an obligation to have enough of a resource base to be able to address all the complaints and concerns that are raised by the public and by other professionals. And so we are in the process of building the reserve fund in order to be able to do that. Also in order to be able to provide funding for counseling for victims of sexual abuse by registrants, and to be able to operate the quality assurance and all the other programs that the college undertakes. So at this point, there's no plan to reduce those fees. But just want to be quite clear that we are not the highest by any stretch of all the colleges, and that we work hard at the council and staff level to make sure that we are as effective and efficient as we can be in being the stewards of the resources that the college has available to them. And so we're committed to continuing to look at and be transparent about how we spend money.
Next question is, Is there a specific consent form to be used when providing telemental health?
So no is the short answer. We have not provided specific forms and resist doing that because everybody's practice is so very different. Certainly the electronic practice guideline and the checklist that has been available for some time now include elements and direction around that. We did in the beginning of the pandemic post links to resources from, for example, telehealth and Ontario Health, which are two of the organizations that are involved with electronic practice and electronic medical practice, starting to broaden into allied health electronic practice over the years. That included resources on that front. And we'd encourage you to take a look at those. There are a number of different options available around consent and the forms that you might want to use, but we've chosen not to provide an actual template, recognizing that everybody's practice is so different.
Next question is it appropriate to send a release of information request to be signed by a CL using Adobe? Is a password required?
Can anybody tell me what a CL is? Because I'm not sure what that short form
I think it means it's a client.
Oh, thank you. So, certainly there's information available about the use of password protection. There is information available on the site around ensuring that your communication with your clients about the limitations of security of email are there. But we offer that up as guidance. It comes down to a number of different things. The client's ability to use technology. One of the things that we've heard during the pandemic is that for people who are not in safe domestic situations, sometimes struggle with using a shared computer when it's related to their therapy, whether it's for the purposes of actually doing a Zoom or other platform virtual therapy appointment, or whether it's for the exchange of documentation. So I'd encourage you to take all those things into account. We're aware that registrants are using password protected documents and that's not unreasonable. We just caution you to make sure you have all the thinking and the steps in place to make sure that what you're doing is as secure as it possibly can be, and that your client is aware of and accepts any risks that come with that kind of communication.
Maybe Deb, I'll chime in on this one as well. So we've had this conversation around committees and around COVID and our having to move to electronic practice. One of the most important things is to ensure that you've documented. So if, for instance, you're sending out a consent for telehealth and asking your client to sign it, scan it, and send it back, you would ask them to password protect it. If they don't have access to a scanner, they don't have the electronic means to actually give you that back in writing as they would in person, and they just give you, or that they just consent verbally to doing it, just ensure, again, this is extraordinary times, ICRC is aware of that you document all of your actions, the date, and the conversation that you had around consent with your client. The other really important piece for me, just hearing the questions today, is the college is really efficient and effective at answering questions. So if you're emailing to info@crpo.ca or you're calling the practice advisory, these questions are, can be answered. It's great that we have all hundreds of people here because, we're getting a group discussion, but they're very, very good at responding and very knowledgeable to respond to these kinds of questions. But during these extraordinary times, please just ensure that you document whatever the actions are and the client consents. So if there is ever any question, it's written. We say if it's not written, it doesn't exist. That's something we often say around the ICRC table. It must be written in order for us to ensure that it actually happens. So just make sure that you document.
Thank you, Shelley. Yeah, those are great additions.
Next, we have a question about the Controlled Act and additional training. In order to practice the Controlled Act of psychotherapy, what additional trainings are required? For example, medical doctors working with patients who have concurrent disorders need to take the CAMH U of T medical faculty endorsed concurrent disorder certificate? What defines training for the actual controlled act of psychotherapy?
Okay, thank you. So as with the rest of psychotherapy education, CRPO has established a set of entry to practice competencies that are expected of anybody joining the profession. As far as the controlled act is concerned, the expectation would be that it's included in the training that people receive prior to entry to practice. Certainly, we understand that additional ongoing education can be required relative to different modalities and specialties and populations that you may wish to serve, but there is no, sort of one and done controlled act education expectation. You'll note that the standards say you must work within your scope, and if you're outside your scope or think you're going to be, you need to seek clinical supervision and appropriate support and education. So, for an entry to practice registrant, the requirement that you continue to be supervised by a qualified clinical supervisor may be the place where you explore your competence with the controlled act and ensure that you have that competence before you work independently. But our expectation is that you will graduate from your program and come into the college application process, or you will be finishing your program and coming into the registration process with the controlled act behind you. We recognize that for some programs where the clinical experience component is limited or is limited to non-RP supervisors, that this may be difficult. The expectation would be that you would gain that competence and ensure you had it before you started your work independently.
Okay, next question is, according to the definition, the practice of psychotherapy is the assessment and treatment of cognitive, emotional, or behavioral disturbances by psychotherapeutic means, delivered through a therapeutic relationship based primarily on verbal or nonverbal communication. My question is that if RPs are able to assess the cognitive, emotional, or behavioral issues, then why are they not allowed to diagnose that specific condition the client is suffering from?
Good question. So diagnosis, as you're probably aware from your question, is one of the controlled acts under the RHPA. And so like the controlled act of psychotherapy, it's something that has been deemed to be unsafe if completed or carried out by somebody who is not qualified. The expectation around being able to access a controlled act is that you have the education and the training and the ongoing accountability. It is not something that has been included in the psychotherapy scope of practice, and so is not something that has been sought as a controlled act for registered psychotherapists. This is a decision that was made by government at the time when they regulated RPs, and it's interesting because the controlled act of communicating a diagnosis is one that other professions outside medicine have struggled hard and long in order to achieve, and the government has been quite reluctant historically to provide that. Looking for scope changes is something that that colleges can consider. It is often something that's brought forward by the profession as a requirement, and it would really need to be backed by a demonstration that not having that controlled act is detrimental to the profession's ability to provide care. So this is not something that has been raised as a significant issue amongst practitioners, but definitely interested to hear that that's something that you're sort of thinking is the case. And I'd urge you can certainly follow up with an info@crpo.ca email if you want to see this sort of put on the radar for discussion, but I can say that at this point it's not something that the college has been considering or has on the radar to consider in the immediate future.
The next two questions are regarding public engagement.
Okay.
I'm going to combine the two. What exactly is CRPO doing to change the image of registered psychotherapy in the province? I see teaching the public about this new college as a role for CRPO. Psychiatrists, social workers are well known in the community, RPs are not. On the national news coverage, social workers, psychiatrists are interviewed. Is there something you can do to help the public with this? Public service announcements, giving interviews about what you do on television, etc.
Okay, that's a good question and lots of parts to it. So the college's role in communicating with the public is around the availability of the college to respond to concerns about psychotherapists, or to explain the scope of practice and what to expect from a psychotherapist. So there's a line certainly between sort of advertising the services of psychotherapists and making sure that the scope of practice and the quality and accountability of psychotherapy services is made clear to the public. So certainly part of our public engagement will be about the information we share, how we share it, whether it's useful. Are there other mechanisms that we could employ to get the word about the regulation of the profession of psychotherapy out there more broadly? I will say, and this is not by way of an excuse, but just clarification, that colleges struggle to get their message out there in terms of what they do and what their role is. Typically, people don't think about regulatory colleges until they need them. So we track, for example, how many hits we get on our public register. We've done work, and we will be doing work in the future to make it more accessible so that if somebody in the public wants to search and find out about psychotherapists in their area, they can do that. In terms of the messaging that CRPO would be putting out there, it would be very clear that psychotherapists are educated, qualified, safe, and accountable practitioners. And certainly at every opportunity that we have, we provide that information. If there are requests for interviews, we gladly take them. I was interviewed by a CBC reporter last week to talk about in-person practice. So they are starting to seek us out. And certainly one of the conversations we need to have at the council table is about what our messaging delivery needs to look like. We already know what our messaging content needs to be, but what does that delivery need to look like? So we will be working more and more on that to make sure that the accountability and the safe and ethical care, quality care that psychotherapists provide is transmitted by their colleagues.
Okay, we received a couple of questions about CRPO's role in having our fees for service regulated by FSCO in the way that other health professions are.
Yeah, the financial commissioners, what's the S stand for, of Ontario. So that is the table that we are currently at. We are involved in conversations with the FSCO looking at assessment and the work that psychotherapists do. We have written to them, and the response we got is that the next time that they open the schedule of benefits, that would be the opportunity to get RPs on the list appropriately and properly. So we are engaged on that front. We are, sort of at the pace that the ministry is running. And so it is work that's ongoing, and we will report back to you on that front.
Next is a peer circles question.
Okay.
Could you provide access to the material that supports the peer circles on informed consent to the recognized education programs so that we can ensure that we are covering core content in our programming? And is there still a need for more peer learning circle leaders, so facilitators?
Yep,
that's
perfect.
it.
So for sure, hopefully the person asking the question was part of our initial meeting where we spoke to the education programs, and not just the recognized programs, but we're quite happy to have that content available to all of the education and training programs. We want to make sure that the delivery of the materials happens within the confines of sort of the peer circle model. But yes, absolutely, our intention of sharing the cases and the work that went into developing them and the support materials with the education and training programs so that you can use it. We are happy to see you delivering that content to your students as much and as often as possible. Just for everybody's interest, our goal is to actually run the Peer Circles program every year, where our intention is to create new case studies. As I said, this year the subject is informed consent, but we will be using that regulatory problem identification and data mining work that I talked about to find topics that will be current and relevant and will address the real on the ground needs of psychotherapists in practice. So thank you for that question. Happy to provide it.
The next question is more of a comment, maybe. Would love to connect with other Indigenous RPs. Shelley, I don't know if you know of any kind of mechanism to connect with other Indigenous RPs.
Not offhand. No, we have certainly made effort. Well, we have made effort and to have Northern representation around the table for sure. That in part of our work over the last year or so. We have right now a non-elected committee member and a council member from the North, representation from the North.
And I would just add, as a plug for our association colleagues, I know that a couple of the associations have Indigenous practice groups. And so I suspect that they would probably be the best way for you to, if you want to make that connection, reach out. I'm sure they would be happy to plug you into whatever work they have going on that front. So I would encourage you to reach out.
I just noticed actually that Brenda Sedgwick, who is our non-elected council member representing the North, has written that CCPA has an Indigenous circle.
Right.
That's
yeah.
the Canadian Counseling and Psychotherapy Association. Thanks, Brenda.
The next question is a follow-up to the clinical judgment and in-person services. What if clients refuse teletherapy and want in-person services, even though they have higher risks regarding COVID? For example, medical status or age?
Yeah, we've heard that from a couple of therapists, and I recognize that that is a very difficult spot for you to be as a provider. I appreciate that it can, in some instances, come down to feeling like you're making decisions on behalf of clients that they might not necessarily agree with. I think that communication, as always, very important to make sure that you're having clear conversations with your clients about what you can and can't do. And, you know, we've heard that question from both sides, in fact, from clients who insist that they want to be seen, and the therapist is, you know, in a vulnerable position themselves and unable to provide that care. So there is a balance to be had. And so ultimately, if the decision on your part is because you're unable to provide in-person care, and that's justified, then, you know, clearly that's the decision you need to make. At this point, you're allowed to see clients in person, provided that you can put the appropriate and needed infection prevention and control measures in place. And so certainly, if you can do that and somebody prefers to be seen and you deem that to be appropriate, you are at liberty to do it. But I do recognize that if you have a client who you feel shouldn't be seen, you have to work with them to make a decision. As with Shelley's answer around consent, I would acknowledge that these are strange times, encourage you to be very careful in your documentation and to be really clear about why decisions are being made, and then to work with the client to the best possible extent. Ultimately, if the client insists they need to be seen and you can't see them, you know, the referral standard to some extent is relevant because it would guide you in making a referral to another provider who perhaps could see them in person. But again, recognize that there may not be another provider who's willing or able, and that may not be the preferred solution. So we just encourage you to explore all the options, make sure that you're communicating very clearly and you're documenting it. I'm sorry, that's not, I recognize as I speak that that's probably not a very satisfying answer, but that in fact is the answer.
When booking online, can clients be asked to pay the fee at the same time prior to the session?
You know what, it's a good question, and I'm sure the standard speaks to that. I don't want to, I don't want to speak to something I'm not 100% sure of, and so I would need to look at it. I would refer you to the billing standard. I guess the pieces to keep in mind is that you need to be transparent and consistent, and the client needs to know what they're signing up for. If there are problems that arise because of prepayment, you need to be clear on what they might be and work to address them. But I'm sorry, I don't want to misspeak and say that I know verbatim what the standard says when I don't. But I would encourage you to have a look at it. And if you have questions, send that. That's a perfect question for the practice at crpo.ca line. So send that one over, and I will pull up the standard and answer properly.
Maybe I'll weigh in on that one, Deb.
Please.
Again, not misspeaking and not having the standard in front of me. It is not uncommon practice for therapists and training institutes to ask clients to pay their fee before they begin their session. Some therapists ask after the session, some therapists ask before the session, but asking a client, you really have to justify asking a client to pay online, as that is not common practice when they book. It's actually either before or after the session. So you would really, have to justify the reasoning or have a policy around cancellation but I think, it needs a more in-depth conversation with practice advisory.
Yeah, and one of the things that I will note that Shelley's tricked me to is one of the things that we've encouraged people is to have a more flexible cancellation policy in response to what's going on with COVID-19. And just because of the in-person stuff, you definitely don't want somebody who is feeling unwell or who's been exposed coming in person. The other factors around people trying to work remotely and run homes and professional lives and manage with everybody working from home or children being in the house makes things more complicated. So from the start, we've encouraged people to consider how their cancellation policy might need to be considered and potentially adjusted during what we're going through right now.
Again, I'll weigh in again, Deb, that it's important to recognize that for many of us practicing that our normal processes have had to be adjusted to accommodate COVID. And so trying to be paperless and everything through email and, everything through Interact rather than any other form of payment. So we have had to alter our practices. And I think having a system that's safe, that's ethical, that's professional, and that's justifiable in terms of how you're changing up your practice, also acknowledging that changing it up can often be complicated and can be frustrating for clients. But I think, really thinking it through, consulting with your colleagues. I'm here in Ottawa, and many of us sort of shoot emails back and forth. How are you running this? How are you doing that? How have you changed this? So we've really come up with a good system to be able to continue our work safely and effectively and professionally electronically, including cancellation policies.
Just scrolling through the questions that we received in the chat box, and I believe that all of them have now been addressed.
Wow.
If that's not the case, please enter it in there again. Oh, we have one more, sorry. This one just came in, it's a long one. A big picture question. I'm curious about how religious, spiritual, meaning-making beliefs or related values-based considerations have been part of discussions. This might be an overly self-evident question, but in my experience, the obvious can be important for transparency of shared purposes, such as the value of inclusion and diversity. These values, I believe, form boundaries for safe and effective therapy, as well as the daily functioning of CRPO, as in one of your examples using the right touch. Values might include recognition of such competency-based practices as respect, safety, autonomy, openness to growth, equality of all people, incorporation of and reflections upon lived experiences, integration of diverse perspectives, interdependence in the community as we are both shaped by and shaping of systemic barriers and systemic resolutions. Please comment on CRPO values that inform such things as collaborative system changes.
That is a long question. Okay, I'll do my best. Starting at the beginning, around religious, spiritual meaning making and beliefs. So certainly I know that in the days before my arrival at the college, there were long and thoughtful conversations and deliberation around how spiritual care providers could be invited into the regulatory tent, as it were. And I think that the Transitional Council paid a lot of attention to how those pieces of religious and spiritual beliefs and psychotherapy intersected. And so we do have a number of registrants who work in that modality. And we're actually, one of the pieces in our diversity efforts around appointments was to be sure to include spiritual or pastoral care providers. So we're going to have a couple of voices added to the table on that front. I'm not sure that I'm answering the question properly, but certainly I'm looking at the list in the chat feature now. All of those values, respect, safety, openness to growth, equality of all people, those are things that are covered by the entry to practice competency expectations around the ability of registered psychotherapists to serve people from very diverse backgrounds of lived and personal experiences. And so I believe that they are very much a part of the expectation that council brings to the table when they're evaluating applications for registration, when they're looking at quality assurance submissions, and definitely when they're looking at evidence in a complaints case that involves allegations that might touch on the ability of a registered psychotherapist to embody those expectations and principles. So certainly CRPO's values are aligned with the code of ethics that our professional members are expected to abide by. And so I think that, they are included in the deliberations that are made on a regulatory decision-making front. And as I said, that I think that the inclusion of a couple of new voices at the table where we invited the applicants from pastoral and spiritual care modality to become part of the committee structure through a non-elected appointment is something that we're going to benefit from over the coming year. So Daniel, I hope that answers your question. Clearly very well thought through, and I'm happy to engage more. If not, please feel free to pop that in the chat. I see we have a few more questions coming in. So if we can't loop back to you, please feel free to reach out to me through the practice email.
Great. I think one more question. Is there a specific time frame for completion of notes? I didn't see one in the professional practice standard for record keeping. It references timely and accurate record keeping. I know some colleges specifically state 24 to 48 business hours.
Right. So no, we have not got an hourly framework in place. Sort of generally speaking, the college's approach is to recognize the diversity of practice, as I've said a couple of times, and to not be so prescriptive as to tell you, under what circumstances 24 hours versus 48 might constitute timely. I would suggest that, notes that you do in the moment are the most reliable or immediately following therapy are the most reliable and effective in terms of being able to document from a regulatory perspective. Did you undertake informed consent in the right way? Did it include the right elements? Was all the information covered appropriately? But we don't have those hours in there. Shelley, I don't know if you want to speak to best practices. I think that that may differ from one modality to the next.
Sure. So thanks. My hope would be that your training programs would have prepared you for that and set sort of an expectation, self-regulated expectation, of course. The standard is typically that we see clients for about 45 to 50 minutes, and then we write our note after after the session and seeing our next client. That's typically across all the psychotherapy professions. However, there's also there's what's ideal and then what's practical, and sometimes that's not possible. I've seen therapists who take notes during session and then transcribe those notes after session, or at the end of the day. It really depends on the busyness of your practice. I think what Deb said is really important, that best practice is to take notes right after the session, because you have memory, especially if you're a therapist who doesn't take notes during session. It's very hard, to remember tomorrow or the next day what actually happened in the session. And to be honest, I think putting an effective system into place is really prudent. One of our big issues at ICR often is the quality of notes that we see, where we can't even, it's like chicken scratch that we can't even read. So, and that becomes problematic, because then, we don't really have any kind of evidence, or we can't substantiate what it is that you're actually saying is in the notes. So I think best practice would be to, after the session, if you can, to sit down, write the note. An experienced practitioner, it shouldn't take you more than 10 minutes to write a note. They don't need to be long and detailed and comprehensive. And then, see your next client. So I hope that's helpful.
Thank you, Shelley.
And one more question came in, another record-keeping question with regard to the content of each session. Is the counselor's clinical impression a mandatory paragraph of the notes?
Again, I think that the content of the notes should be driven by your training and the requirements of the kind of therapy that you're practicing. Certainly, I would encourage you to have a look at the record keeping standard. But again, it's we're not so prescriptive as to say this is what must be included in the note. If you're certainly take a look at the standard, as I said, and there's actually a record keeping checklist included. What I would encourage you to do is go through it and have a look at a record where you didn't include that paragraph on the counselor's clinical impression, and make sure that, despite having not included it, that you were able to cover off all the elements that are required in that records checklist. But I don't know that we would be so prescriptive to tell you what every record needs to include. Shelley, is that fair? Would you like to add to that?
Yeah, I think, again, always, referring to the standards and the checklist is actually very, very helpful. Just sort of in terms of like best practice, the SOAP model for record taking across healthcare professions is typically used. So that's, you have a subjective, objective assessment and plan. That really covers all the bases from, what happened in the session, to your assessment of the session, and then your plan moving forward. And I know that many of the training programs, and I'm speaking as a trainer, I guess now, many training programs do use this model, and so that might be something you just want to look up in terms of, and then they've done their due diligence and their research to look at what are best practices in the field and how are you covering all the bases to ensure that you've done your due diligence in meeting your own practice standards.
Thanks, Shelley.
I've had a couple of questions come in to me privately, and they are, any update on the document CRPO was working on regarding working with minors?
I'm not familiar. I'm not sure what document they're referring to, I'm afraid.
Okay, I will move on to the next.
Thank you.
When does a client become your responsibility? I ask because I do free 30-minute consult. Then at that session, decide how to move forward. So do I need to do a disposition form, or do you assume the date of the informed consent is the active date for a client being in my practice?
That's a good question, and one of the ones that came up when we were working our way through the Controlled Act issues. I would suggest that the answer is dependent on what the expectations of the client are and the information that you've shared with them. So if you're clear that this is an intake conversation and that you are not engaging in a therapeutic relationship right away, just by virtue of having that appointment and seeing them or speaking to them that first time, and that's what is clearly stated to them, and they understand that the therapeutic relationship isn't established, that you don't make a therapy contract or do the informed consent, then I think it's quite reasonable to say that you're sort of determining that the therapeutic relationship and your responsibility starts after that. Obviously, the exceptions to that would be if somebody arrives in crisis and needs support, that would be sort of, I would suggest under sort of a Good Samaritan kind of clause, and that you would need to make sure that somebody who was expressing intent to harm themselves or somebody else who was unsafe, that you would want to take steps to make sure that, even if it was just engaging another provider or another service. But for the most part, the expectation would be that as long as the understanding of the client is that this first visit is not your establishing a psychotherapeutic relationship, that wouldn't be unreasonable. Can I just say that the person who made the inquiry about the document, can you please send an email? Our emails are going to be flooded, so that I can clarify what that was and provide you with an answer.
Sure. They actually followed up in the chat if you want to address it now, or it's up to you.
Sure. I'm honestly not clear what it is, but happy to try.
Sure. So to clarify, in the standards under consent, it says the college may develop detailed guidelines on working with minors in the future.
Okay,
Sorry,
so,
I assumed the college was working on this. I assume there's nothing underway regarding this or plans to undertake it.
So this, yeah, thank you. Nope, totally valid. The standards are up for review this year. We're going to undertake a complete and comprehensive review of standards. And so it'll be at that point that we'll decide whether or not that information is going to be helpful to registrants. I'm hearing maybe it is. And so that's good to know. We'll take that into consideration as the review begins. One of the pieces that I anticipate, of course, we're waiting for council to provide direction on this front. But one of the things that I anticipate is that a lot of the work that we'll be doing will be to actually take the standards and provide more guidance around how to apply them and how they should be interpreted and carried out in various practice settings. And so certainly if your practice involves children and youth, that would be relevant, and that would be one of the places that we'd be looking at to see if there's more that we can offer around specific application of the standards.
All right, being mindful of the time, I think that I can definitively say that this is the last question. What is the view of CRPO for videotaping sessions as a means to record the session?
So that's a very big informed consent question would be my answer. I think that you would need to make sure that you had continued consent. So you're asking every time. You had clear consent. I would suggest in cases where you're doing something new with a client or that is, a little bit more complex, that you make sure that it's written consent. So even in our strange COVID times, I would suggest you need something from the client in writing saying that they consent to it. And then the other side of that conversation would be around treating this as a record. How would you store it? How would you destroy it? How would you ensure that it was secure? And if there was transmission of the record to the client, I don't know that there would be, but if there was any intent that you were really careful and again, clear and upfront and had the consent of the client, and that you were managing this record as securely and safely and appropriately as you would an electronic clinical note or a paper clinical note.
And finally, we have received a couple of questions about whether or not we are recording this session. We are recording the session, and we will post it to our website in the coming week once it's been edited and compiled, and you can share it with your colleagues who were not able to attend today.
Great, thank you. Okay, so I am gonna share my screen again. And I'm going to make sure I advance the slide so that we're not stuck on that question, and hand this back to Shelley for some closing remarks.
Thanks, Deb, and thank you to everybody for attending today. Your questions were great, very informative, and I love the fact that we can kind of disseminate this knowledge to a big group as opposed to, you know, on a one-to-one basis. Although do remember that the practice advisory and the info account is always available at the CRPO. So I just want to say on behalf of the registrar, Deb, and I, that this was not what we had intended. We had hoped to come and see you in person, and we are really hoping and praying that we'll be able to do maybe more of that in the spring. So thank you all. Just in closing, just want to make a comment that as this system becomes more complex, the need for CRPO to effectively navigate the required changes to governance and update stakeholders and registrants becomes more imperative. And when this happens, we fulfill our mandate and meet our regulatory objective of optimal public protection and providing registrants the needed information and guidance to continue their work. We hope that today's town hall has provided you with the necessary information to instill your confidence in the work CRPO is currently undertaking in preparation for significant changes ahead. Thank you all. Stay safe.